Dispatch, what is the location of your emergency?
The location is 9023 Dove Court in Pine Grove Township.
Okay. Tell me exactly what happened.
Well, my father, he's rather old, and he's just having trouble getting out of bed.
Line 595, Warren
And I
Road.
was hoping that you could, maybe send somebody over to help me get him over to the bathroom.
Okay. Are you with him now?
Yes, I am.
And how old is he, sir?
He is 85.
Is he awake?
He is awake.
Is he breathing?
He is breathing.
Okay. Is he completely alert?
In the virtual ride-along series, we try to bring you real cases that help you translate classroom theory into actual clinical practice. Today's case illustrates some essential components of the EMS system and some key learning points that will help us save lives. We're going to follow along with Jill and Mackenzie.
We were initially dispatched to a lift assist. The fire department had shown up prior to us.
In this case, the fire department has been called to help somebody back into bed. That's why they call it a lift assist. Well, these calls can appear to be super simple and just no big deal, right? We're just putting somebody back into bed.
And when they arrived, they saw that this patient was quite ill, so they requested us.
Notice how assessment of this patient is complicated by very limited space in this bedroom.
Okay.
Now we know from the fire department and from the family that this patient is just too weak and unable to move.
Doug, you're gonna feel a poke in your arm here. How are you doing, Doug?
The crew is trying to figure out if there in fact is a further problem and the patient really needs to go to the hospital. And that's pretty evident right from the get-go.
Patient was breathing, but it was pretty shallow. All right, Dawn, we're just gonna roll you over a little bit.
They need to move quickly to get the patient out of this environment, but there's not a lot of space to maneuver. Notice how they're putting the patient inside a sheet and using the sheet to carry the patient out. The patient's condition is changing very rapidly.
How are you doing?
And they have to react and begin treating the patient differently. Just a few minutes ago, the patient was breathing on their own just fine. And now, inside the ambulance, they're trying to figure out, is the patient still breathing on their own as well as they were before?
No.
So you see how they begin to escalate their care.
I saw him just take a
Open
gasp
up your
at
eyes.
that.
Can you breathe for me? Take a deep
Give me
breath.
that, really.
First with a non-rebreathing mask, administering additional oxygen, trying to get the patient's O2 sats up. And when that isn't working very well, they're going to switch to a bag valve mask. Notice the masterful job that this firefighter is doing in managing the airway. He's actually holding the mask to form a great seal around the patient's face, kind of forming a C shape to hold the mask, and an E shape with his fingers to pull the jaw up into the mask and form a good seal. Now you'll also notice that after a few breaths, he gets his partner to come help him so that he can hold the bag and his partner can do a better job holding the seal, which is even more ideal. I want you to remember that these bag valve masks hold 1,500 milliliters of air. In fact, we need only 500 milliliters to actually get a breath in. With dead airspace, we really only use 300 milliliters. If we squeeze the entire bag, that means we're giving the patient 3 times the amount of air that they actually need. So notice how careful they are to just give enough air to get chest rise.
95?
This patient is deteriorating rapidly. Their heart rate is slowing way down to the point where we might not even be able to detect a pulse. Medical research has actually taught us that there may be a pulse, but it's undetectable to our fingers or our instruments. And if you can't really feel it, then it's time to start compressions.
Want me to start CPR?
Yeah.
Okay.
He's clamping down on this. You can get me a nasal.
Chest compressions are hard to do well. It's very tiring. In fact, we want to switch compressors every 2 minutes to ensure that they're done properly. So Mackenzie is going to start doing those compressions, but she needs relief really quickly.
I had initiated chest compressions. Only about 2 minutes in, I was getting tired.
Ready for the Lucas backboard? Oh, vomiting.
One of the most important things, aside from knowing your protocols and knowing what to do, is trying to stay calm, which isn't always easy.
Now here at Allina, we use a device, a mechanical CPR device called the Lucas device. There are others on the market, and you should check into what your local area uses. The key to using a mechanical CPR device is that we cannot interrupt CPR for very long. So it's a coordinated approach. Think about pit crew CPR as everybody having a job. We try to interrupt CPR for less than 10 seconds anytime we're checking for a pulse or looking at a rhythm. In this case, they did a great job of getting that device on very quickly.
Yeah, we might be better after the king.
Sometimes using a mechanical CPR device can help make sure that chest compressions are delivered evenly and at the right rate, with the right depth and the right release.
So the Lucas device that we have is really essential in getting good quality CPR and perfusing that brainstem.
Although today we know chest compressions to be one of the most important elements of resuscitation, but it's really a constellation of therapies and procedures that make our resuscitation attempt actually work.
I don't know where my computer is, but we'll find it.
Did you notice that the crew actually attach a rescue pod or impedance threshold device to the bag valve mask? What this device does, it prevents air from rushing in on the upstroke of a chest compression. It's actually a circulatory device. It's helping blood return back to the heart. Another nice feature of the rescue pod is that it has a timing light and therefore guides us into how often we should ventilate.
So every time the light goes off is when they squeeze the bag.
As soon as possible after establishing great compressions and getting an airway in, this crew is looking to insert a more advanced airway. Now they know that the patient vomited earlier, and so they're concerned that the patient may vomit again. While compressions are ongoing, they're going to insert a king airway. This is done very well and very quickly and can be done while compressions are still ongoing. In fact, most of our airway management can be done while CPR is still ongoing. After insertion of the king airway, they have to confirm that it's in the right spot. So you see Jill immediately listening to the stomach. That's the first place we want to listen, just in case we're in the wrong spot and air is entering the stomach. We want to identify that immediately. And in this case, she does. For some reason, this particular placement, which is through no fault of the crew, has ended up in a wrong spot, and it's giving us air entering the stomach.
It is never going to be the same thing twice. Expect the unexpected, because it won't always go exactly as planned.
Notice how, after a few ventilations, stomach contents have begun to come up through the tube. Not only is this a bad sign, but it also can impede the functioning of the ITD or the rescue pod. So upon noticing that, we immediately have to take action, and this crew is doing that. After removing the rescue pod, deflating the cuff, removing the king airway, it's going to be super important that this patient gets suctioned so we clear the airway again before we give a breath. Now we can return to some basic airway maneuvers with some simple adjuncts to make sure that we're ventilating the patient, reoxygenating, before we attempt another airway.
You ready for a vaso?
Yep.
Okay.
If you could just mark your time, that would be
Yep.
awesome. Focus the Pete style it. Naturally.
10:22 vasos in.
10:22, thank you.
Yep.
When you're inserting a nasal airway, you may find that there is resistance. Gently put pressure on the airway, advancing it past whatever it is that it's caught up on. If you encounter great resistance, then you want to stop because it might be up against some sort of polyp or turbinate or something that might cause bleeding. In this case, notice how they're gently twisting the airway, and because it's properly lubricated, it's going to pass through without a problem.
I did not tell dispatch. We had an arrest.
Remember how patients don't really read the textbook and they don't present like they're supposed to?
It was an arrest.
Well, this patient had an unusual amount of stiffness to their airway and to their neck. We don't really know why. When the crew identified that, they knew they had a difficult airway. One of the tools available to us at Allina is a video laryngoscope. Video laryngoscopy, as it's called, is not a very common procedure today in EMS. In our particular version of the tool, we have a connector that goes into the same computer we use for electronic charting. It's just a USB port. It turns our entire laptop into a screen.
We used video scope intubation, which was a really helpful tool with someone who has so many secretions.
Notice as they begin to insert the laryngoscope, we begin to get a very clear view of the airway anatomy.
See around his tongue, actually.
This is rare footage, and we're going to have an opportunity to talk about some very unique and very special structures that are essential to identify when we're doing endotracheal intubation. Notice first how we see the epiglottis. That's the large sort of hat that you see, that structure that covers up the trachea. This device lifts that without actually having to line up the planes of the airway. As we advance the tube, we begin to see the structures bouncing up and down from the chest compressions. That's really normal, especially during mechanical CPR. We can take our time and look and see where exactly that tube needs to go. Notice how you can begin to see the vocal cords. On the upstroke of the compression, we have a much clearer view of those. Notice what's happening as Jill begins to advance the tube through the glottic opening, trying to get it through the vocal cords. She's inadvertently picked up a part of the epiglottis, so she has to back off. McKinsey is appropriately asking that she consider removing the stylet.
Oh, pull the stylus out. I don't need that.
Yeah, but it's still really tight.
Now, helpful suggestions like this, especially when they relate to safety, are key and they're part of our crew resource management techniques. When she removed the stylet, she's now got a much more flexible tube. As the tube begins to advance now, it will pass through the cords. Notice the pool of fluid, possibly stomach contents or blood, that is accumulated right underneath the airway. It's not obstructing our view in this case, but it's something to keep in mind because we could suction that out once we get the airway secured.
Okay, breath.
I'm seeing chest rise.
Breath.
24.
Good. Breath.
Okay.
Got
Good.
fluid
Let's
in
pop on that end title, please.
Yep.
Got fluid in the tube too.
Once that tube is through the cords,
Okay.
Okay.
we have a few confirmatory steps that are critical before the procedure is finished. The first is to again listen to the stomach, make sure that no air is going in, make sure we have lung sounds, and of course, attach an end tidal CO2 detector, which in this case is attached to our EKG monitor. Once all of those are done, we can make sure that there's good pulse oximetry, that we get a reading from the end tidal CO2.
Okay. I just
Goes
don't
on
want
top,
to get.
doesn't it? Or below?
I'm trying to get this
Below
out.
below the rescue pod.
Okay.
By the way. There you go.
Floor.
We're also going to record the depth of the endotracheal tube, how far we had to insert it, so that if it moves up or down, we'll know that there was a change. It's usually a marking on the tube that shows 22 to 24 or 25 centimeters.
Are you good? Do you want to get going?
See, yeah, I'm
Okay.
good. I'll take Darren with me though, please.
Jill is using a commercially available endotracheal tube holder to attach that tube and make sure it's secured so it doesn't move. Another technique is to find a cervical collar and place it on the patient. Even though there's no cervical injury, it helps us prevent movement forwards and backwards so that the tube doesn't become dislodged. Reassessment of lung sounds anytime you're moving or have moved the patient is key. The tube can get dislodged. So you can see Jill is double checking to make sure everything is where it's supposed to be. Things have now settled down during the transport, and the first responder is able to tell us a little bit more about what the scene was like before the crew arrived.
Here we go.
So initial presentation. Legs were down on the bed. He was partway dressed, and he was looking around, but he never gave us a cognizance.
Okay.
So radial pulses were poor, and I couldn't get a brachial pulse, so I lifted up his legs, and then we called you to upgrade to emergency.
Okay.
And once I lifted his legs up, then I could get a brachial, and that's when I got that initial blood
Gotcha.
pressure at 70. So
Of course, notifying the hospital is another key element, as always, and Jill here is alerting them that the cardiac arrest is not improving, so they know they have a patient who is asystolic.
We are coming to you code 3 with a cardiac arrest. He's in asystole. We have been doing CPR, so we pretty much witnessed him cardiac arrest. His son called this morning because he was unresponsive. He was breathing when fire first got there, but unresponsive. We got him out to the ambulance and lost his pulse. We started CPR. We've given him 1 epi, 1 vaso. We do have him tubed, intubated, and we should be to you folks, I'm guessing about 5 to 8 minutes.
We have 1 IV that was established in the arm, which is how the crew has been giving medications. It's always good to establish a 2nd IV on any critical patient. In this case, Jill is going to use an intraosseous line for that 2nd access point. Notice how quickly and easily these can be inserted. In fact, check your local guidelines. Your medical director may want you to insert the IO first and an IV secondarily. As we approach the hospital, if you have time, it's good to begin to look around and make sure that we're ready to unload the patient. Oftentimes, cords can get tangled up in the middle of a cardiac arrest, and it's important to make sure you understand what devices are coming with you, what devices are staying in the ambulance, what cords might be wrapped around the stretcher or the oxygen or the EKG machine, so that nothing gets accidentally ripped out. It is really common in your initial cardiac arrest to have such chaos that IV lines get ripped out, endotracheal tubes get ripped out, and when that happens, you have to start over. That's terrible for patient care. So taking an extra second to be smooth. Remember, slow is smooth and smooth is fast.
Are you going in with the monitor or just disconnecting?
I think we got enough hands. We can go in with the monitor.
If there was any chance of this patient surviving, and there's always that hope, that chance, this crew was the right crew. They were prepared, they responded appropriately when they had a very difficult airway, they handled themselves masterfully and provided the best care that anyone could provide under very difficult circumstances.
We're going to try and bring the monitor in here too, so as we were pulling him out of the ambulance, once we got to the hospital, there was lots of cords, there's lots of things that can't be moved and touched and pulled. I ended up taking that IV line and moving it down by his feet because that's where the fewer amount of cords where nobody's going to trip up on it.
How long has it been? I lost track of time.
Well, 10:15 was when we gave the epi, so.
I want you to be psychologically, emotionally prepared for what happens during a cardiac arrest in the field. It is very chaotic, especially those first few that really can catch you off guard. And since most of these end in death, we need to prepare for the next steps after that occurs. In this case, we transported the patient to the hospital, but most often we will cease resuscitation measures on scene. If you can go out there and stay calm in the midst of this type of chaos and things not working exactly like they should, you will stand a much better chance of making that impact and saving a life. And after all, that is why we're here.